Hello, my name is Rachel Pata, and I am a professor in the entry-level Doctor of Physical Therapy program at Quinnipiac University. Today, I will discuss the article, Simulation-Based Cardiopulmonary Skills Checklist, Assessment of Inter-Rater Reliability, a study that I co-authored with 3 of my Doctor of Physical Therapy students and a professor in the School of Medicine. The use of experiential learning, in particular high-fidelity simulation, is growing in physical therapy education. Simulation allows students hands-on practice in an environment that does not pose risk to a patient. It is a great place to practice. The use of simulation has been shown to improve carryover of knowledge and skills, as well as student confidence and clinical readiness. High-fidelity mannequins are especially helpful for practicing the cardiopulmonary examination due to the ability to simulate many physiologic functions, including heart and lung sounds, chest rise, vocalization, and telemetry monitoring. When using high-fidelity simulation, best practice must be considered. Every student experience should include a pre-briefing, a psychomotor component or hands-on skills, and a debriefing or providing feedback or time for the students to reflect. This debriefing component can often be missed or cut short due to time constraints with our students. It can also be difficult to provide a structured feedback for students without reliable assessment measures of their performance. Prior to this study, there was no tool available to assess student performance on the cardiopulmonary examination in the simulation environment. In this study, we used CAPTE guidelines, as well as the recently published entry-level competencies in cardiovascular and pulmonary physical therapy to develop a checklist assessment tool of students performing a cardiopulmonary exam. The checklist is divided into 6 sections. It includes communication or the patient introduction, vital signs, inspection, palpation, lung auscultation, and heart auscultation. The intention of the checklist tool is to provide a simple assessment tool of students to ensure competence in foundational cardiopulmonary examination skills. In my experience, practical examinations are helpful, but they often only require students to perform a couple of skills, and a more holistic view of the student performance can be missed. Demonstrating basic competence in performing skills is also necessary before moving on to case application and prioritization. This tool can ensure students are ready for this next step. In this study, 73 students in their foundational cardiopulmonary course independently completed a cardiopulmonary exam on a high-fidelity mannequin in our simulation laboratory. Students were randomly placed into one of 3 simulation rooms with the same setup and a third-year Doctor of Physical Therapy student playing the voice of the patient from the control room. Each experience was recorded for later viewing and scoring. Prior to this, students had an orientation to the simulation area, as well as lecture and laboratory experiences on the acute care environment, vital signs, telemetry monitoring, and of course, the cardiopulmonary exam. Students were also pre-briefed on the expectations of the experience and provided a copy of the assessment tool. They were allotted 15 minutes to complete their exam. After the experience, 25 of the videos were randomly selected, viewed, and scored by 3 of our laboratory instructors. Each instructor had been trained on the cardiopulmonary exam, as well as use of this tool. The tool showed strong inter-rater reliability overall, and each section had good to near perfect reliability, meaning that sections can also be used independently of each other. Student performance was also assessed and on average, students got just over 80% of the items correct. Students had the most difficulty clearly explaining skills, as well as interpreting auscultation sounds. This is not surprising given previous literature that shows difficulty with auscultation. Building an extra practice time for students to do auscultation is recommended. In conclusion, this tool is easy to use and can be used by multiple instructors with confidence that scoring is fair. I must note there were 5 questions that had less than 80% agreement between graders, and suggestions for slight modifications to these questions and rationale can be found in the manuscript. If you do not have a high-fidelity mannequin, it is likely that similar results would be found with use of a standardized patient, along with a telemetry monitor and simulated auscultation. However, this needs to be further investigated. Should you have any questions at all, please feel free to contact me. I hope you enjoy the manuscript.